for the potential treatment of rare diseases using natural products. My book that I mentioned was self-published out of my company, Live Full Out Media, and the rest I mentioned. I do have bone support products, and I will mention those. So this is the book. Those are just a couple of a few of the reviews that it's gotten. And these are the products. For full disclosure, I really encourage everybody to do your homework, do your research. There are citations all throughout this presentation. There are citations all throughout my book. Everything that I'm telling you is accurate, but I also encourage people, don't just believe me. You can always go and do your own research. I have all the PDFs that are referenced in here. So if anybody wants that, feel free to reach out to me. I'm happy to send any of this information to anybody. So let's just move on then. What the issue seems to be, of course, is that the osteoporosis is not just about bone density. It's a condition that predisposes somebody to a fracture. So a bone density test, and any test, is only as useful as it is as it can predict fractures. Similarly, any treatment that we recommend, any recommendation at all, diet, lifestyle, dietary supplements, pharmaceuticals, whatever we are recommending, are only as useful as they've been shown, not just to change a number on a test, but to reduce fractures. 80% of osteoporosis is in women, and the majority of that is postmenopausal osteoporosis. The fastest bone loss occurs in women when they hit menopause and for the 10 years after. As I mentioned, there are a lot of people that have it, 53 million people, either with osteoporosis or at risk. There are, by just a couple of years, we're talking about 3 million expected fractures and tens of billions of dollars to the healthcare system. And that doesn't even, take into account, I think, the impact to families and the communities when it comes to having to have caregivers that are family members. If you break a hip, if you have osteoporosis and you break a hip, there's up to a 40% chance that you're going to die within a year. The most often cited statistic is 20%. The biggest risk is within the first 6 months, and then it begins to decline from there. And then if you do survive, though, half of the people who survive don't end up getting their full level of pain-free life and mobility back. And so a lot of people end up needing ongoing care. And so there's a lot of ancillary costs that I don't think are factored into this. Osteoporosis, it has a greater impact on disability adjusted life years than hypertension, breast cancer, rheumatoid arthritis, stomach cancer, prostate cancer, ovarian cancer, and Parkinson's disease. So I think I've driven the issue home. It's a big. There we go. Now I'm unmuted. One of the biggest challenges, and Dr. Clearfield mentioned it, it's not something that he, if I'm mischaracterizing, please let me know, but deals with that often or sees that often. And there was a study that came out of Europe that showed that primary care doctors in Europe are really not sure how to treat osteoporosis. There's a lot of confusion, and I believe it's the same situation in the US. There is no specialty for osteoporosis. It is usually the primary care docs who are the ones who do the screening, order the DEXA tests, manage the patient, make the recommendations, and do the follow-up. And yet in this study that came out of Europe, and I believe it's the same in the US, there's a lot of confusion. And then the time that it takes to have the more nuanced conversations around diet and lifestyle, they don't have the time because there's pressure for reimbursement and to see more patients. And also, most doctors don't feel confident knowing the information and feeling competent to have those conversations around diet and lifestyle and exercise in any greater detail. So that's why the default often is medications. That's one of the reasons. And one of the reasons why I think the outcomes are so poor. If you're looking at screening and somebody comes in quick physical exam may give you a little bit of information of whether they should go for a bone density test. If they can't stand with their occiput against the wall, back against the wall, with their occiput touching a wall, they're a little bit kyphotic at that point. That may be an indication if they've lost about over 2 centimeters over 1 to 3 years. Being thin, less than 112 pounds is a risk. If they've been losing teeth. Those are risks for osteoporosis and indications that you may want to get some testing done. The latest US PSTF recommendations is that screening should be for all women 65 years or older, and for postmenopausal women less than 65 years old. So if they've had had their ovaries removed, then, or somehow they've been put into menopause prematurely, then they need to have potentially have screening. It's estimated, though, that 30% of fractures, hip fractures, occur in men. However, the task force does not recommend men get screened for osteoporosis, unfortunately. Some organizations take a more nuanced approach. The Bone Health and Osteoporosis Foundation, for example, recommends that when there are other risk factors, even when they're less than 65, not just if they're in menopause while younger than 65, but if they're comorbidities, for example, medications that they're taking. And I'm going to talk a little bit about medication-induced osteoporosis because it's a big problem and it's a largely unrecognized problem beyond what I think we all recognize as an issue like prednisone, systemic, oral prednisone. Interestingly enough, though, the risk for fractures when somebody's on prednisone goes up even before the changes are seen on a bone density test. Similarly, in terms of screening, any adult over 50 years old who breaks a bone, it's recommended by the Bone Health and Osteoporosis Foundation that they get screened for osteoporosis. Despite the limitations of the bone density test, in terms of its ability to predict fractures, that is the diagnostic criteria of osteoporosis. We do need it in order to diagnose the disease, and it is one variable that can be tracked over time. So screening rates, unfortunately, despite how many people are at risk, despite the recommendations, are poor. We're talking about 30% of eligible women and only 4% of eligible men are tested. And when you're looking at Medicare population, we're talking only about 5.5% are getting bone density tests. There's a lot of room for improvement here. There's an online tool, Frax Risk Assessment tool, that patients can do. It's interesting. I think one of the it has been validated, but I think one of the main benefits of the Frax tool, as well as the bone density test, are that it opens up the door to a conversation, and it opens up the door for people to be more open to being proactive and involved in improving their health. So let's just talk briefly a little bit more about the DEXA test. A central DEXA bone density test is what's required for the diagnosis, not a peripheral bone density test. The peripheral bone density test, though, has some advantages in that it's portable. It can be taken to health fairs, for example, and then if that's low, they can be sent for a central DEXA. Radiation exposures is very low. I mentioned the peripheral DEXA briefly. And I'm going to go through some of these slides because I really want to get more towards the approach to improving bone health and reducing fracture risk, as well as making sure that I have enough time for questions. So the definition of osteoporosis is a T-score of -2.5 or lower. Osteopenia is -1 to -2.5. And that is based on a comparison with, if it's a woman, with younger women, 20 to 29 years old of the same race. A Z-score, in contrast, compares a bone mineral density of somebody of their same age. Interestingly, a T-score is not applicable to premenopausal women and men less than 50 years old or children. So if you're getting a younger woman screened, you need to be looking at the Z-score. And also a Z-score is important for looking at secondary causes of bone loss, like medication-induced osteoporosis, endocrine abnormalities, autoimmune disease, etc. I talked about how well a bone density test predicts fractures, so there's a little more information there. Interestingly, in 2014, the Annals of Internal Medicine published a paper that stated that among persons receiving FDA-approved osteoporosis pharmaceutical treatments, changes in bone mineral density are not good predictors of the anti-fracture effects. So again, primarily in the clinical encounter, doctors and patients are focusing almost exclusively on bone density. But not only is it a poor predictor of fractures, but now we have a lot of data showing that even when the bone density test is improved by medication, that is actually a poor predictor of its effects, its ability to reduce fractures. There are a lot of potential errors with DEXA scans. Up to 90% of tests in one study contain one or more errors. There could be artifacts, dietary supplements if somebody's taking high doses of calcium, or if they're taking strontium. Strontium is a popular dietary supplement for bone health. It has been shown to reduce fractures in Europe, but it's been taken off the market because a regulatory review of the data has since shown that for every one patient helped in terms of reducing fractures, it's now believed that one patient will have thromboembolism, venous thromboembolism, pulmonary thromboembolism, and so they ended up taking it off the market. In Europe, the drug medication is called strontium ranelate. That's a proprietary form. It's not available in the U.S. In the U.S., you see in dietary supplements strontium as strontium citrate. There is no safety or outcomes data on strontium citrate in terms of clinical trials. All right, so the real risk is breaking your bone. Every 30 seconds, somebody with osteoporosis breaks a bone. And it can lead to further disability and mortality. If you break a hip, the risk for death is elevated for 10 years after that. And in fact, mortality from a hip fracture is greater from your risk of dying from breast cancer in the elderly, if you're over 65 years old. There's the greatest risk of dying is within the first 90 days of a hip fracture. I think I said the first 6 months, but that's true. It goes down after 6 months as well. But within the first 90 days, first 3 months is the biggest risk. Interestingly, this last bullet, hip fracture mortality is almost double in men than in women. There's speculation of why that might be. There's no clear consensus yet, but it does seem that what may be happening is that as people get older, the comorbidities in men seem to be more severe than in women, and that predisposes them to the increased risk of dying from fractures. 40 to 60% of patients who survive don't regain the pre-fracture level of mobility. 50% never return to full function. And in fact, after 1 year, 27% did not regain their full independent mobility in one study. This is important. So 73% of total fractures are non-vertebral fractures. And that's important to know because most of the medications, when you look at the data and start looking at the clinical trials on the medications, they report primarily vertebral fractures. And vertebral fractures, it does increase your risk for mortality up for 5 years after, but it's not as immediately deadly as a hip fracture. That's the most dangerous fracture. And in fact, there are some predictors of mortality that you should be aware of. And if they're in a nursing home, so the different predictors, nursing home versus community dwellers, poor functional status, comorbidities, I mentioned that. And it's important, one of the biggest predictors is gait and mobility. So if you see somebody coming in, and obviously the clinical encounter happens the moment you see the patient, you see them walk, you watch their gait. Are they steady on their feet? How do they get out of a chair? Are they able to get up out of a chair unassisted? That's one of the most validated, or what's the word I'm looking for? That is the best predictor for fractures and mortality is functional status. Osteosarcopenia is another big issue. Muscle wasting, when it's combined with osteoporosis, you've got a higher mortality rate. The mortality rate is higher in men than in women. I don't know why when they have osteosarcopenia, but when you do have osteosarcopenia, you also have 28%, 28.7% of hip fracture patients were diagnosed with this. So look for that as well. It goes back to that functional status, the gait, the muscles, the strength, the balance. 95% of fractures occur because somebody falls. So anything we can do to prevent somebody from falling can reduce their risk for fall-related injuries, including fractures. Long-term mortality, predictors of mortality. I mentioned the quadriceps weakness. I'm not going to belabor this. Gait or balance abnormalities, that's a fall risk. The most consistent predictor of future falls. There are many other risk factors here. Quite a few of them are modifiable risk factors. Medications may be a modifiable risk factor. Environmental hazards, definitely a modifiable risk hazard. So why isn't a bone density test a good predictor of fractures? The reason is because bone is not just minerals. A bone density test only measures the mineral content of bone, but bone is a tissue. All tissues have multiple components, and the minerals are just one component. The extracellular matrix in bone has about 200 non-collagenous proteins and collagen. The major type of collagen in bone is type 1 collagen. And that's actually what gives bone its ultimate quality and strength. If you were to dissolve the collagen in bone and are just left with the minerals, it'd be very brittle, like a column of chalk that breaks easily. If you demineralize the bone, and my histology professor in medical school did this, he brought in demineralized chicken bone that he'd soaked in vinegar, and all that was left then was the collagen, and it's like a rubber chicken. You can bend it, you can twist it, you can pull it, and it doesn't break. That's the power and the strength of collagen and healthy collagen. So the North American Menopause Society has various fracture risk factors. There they are. An interesting history of smoking is not one of them, only current smoking. Previous fracture is a big one. 30% of people who had an osteoporotic fracture within I believe it's 5 years, I've got the slide coming up, will have another fracture. Impaired vision, making sure vision is checked. That's really important. Making sure medications, glucocorticoids, there's more recent research that not just long-term systemic glucocorticoids, but even low dose inhaled glucocorticoids and dose pack, short-term dose pack prednisone increases the risk for fractures. So here's what I mentioned before, the risk after a primary fracture. And it's really important to start thinking, are we trying to prevent a primary fracture or a secondary fracture? And I'll get into that in a few minutes, because the efficacy of the medications are different, whether it's a primary or secondary fracture. Interestingly, the 5-year risk of subsequent fractures was up to 75 to 84 years old, was 42%, even higher than the group as a whole. And in women, once they get up to over 85 years old, it goes down a little bit to 38%, perhaps because they're maybe less mobile at that point. So let's talk about drug-induced osteoporosis. It's a big issue because so many people are on not just single medications, but polypharmacy. And there is no official definition of what polypharmacy is. How many medications does somebody have to take in order for it to be considered polypharmacy? I see in there, the second bullet, and it's an important opportunity for NDs to help. That's a legacy bullet point. I was giving this presentation to a group of naturopathic doctors at a conference. So also for osteopathic doctors, any physicians, it is an important opportunity for all of us to be able to help. But your talk, yes,
we're the renegades, John. So we're good with it.
All right. So you're talking about more, 5 or more non-prescription or prescription medications per week for women 65 years and older, which is the prime demographic who are at the highest risk for osteoporosis. A huge number. 12% in that age group are taking 10 or more medications, either non-prescription or prescription medications per week. So a study looked at drug use before and after fractures. How well are doctors doing? at identifying the medications that have been a problem and switching to safer medications, and they're not doing a great job. What the studies show is that they would switch them if they identified the medication, like prednisone. Glucocorticoids are commonly known to damage bone. So the number of, I'm going to go to the next slide because I think I've got the data on the next slide. Yep. So you can see there oral steroids on the left column prior to fracture, in the 3 months prior to the fracture. After the fracture, they reduced the number of people who were on oral steroids, the number of patients, but that was offset by the number of patients they put on proton pump inhibitors, and the number of patients they put on hypnotics, and the number of patients they put on SSRIs and antipsychotics, all of which either damage bone or increase the risk for falls and fractures. SSRIs, we now know based on some studies, people are taking them long-term. More people than ever are taking SSRIs, that after people who are on them for 1 to 5 years, for every 19 patients taking an SSRI, we would expect one to have a fracture. And I've got that citation and the data in a slide coming up. Similar with proton pump inhibitors that were never approved by the FDA for long-term use. It's available over the counter, as you know, that the PPIs after 4 years of use increase the risk for hip fracture, or associated with an increased risk of hip fracture, by 60%. And like all medications, dose and duration matter. The higher the dose, the longer somebody's taking it, the greater the risk. We see that pattern over and over. So glucocorticoids, up to 50% of patients on chronic glucocorticoids will fracture, and up to 2% of the general population also are actually on long-term glucocorticoid therapy. And now we know that even small doses increase the risk. And for every 10 milligram increase in dose, there was a 62% increase in risk for fractures. When you look at treatment guidelines, glucocorticoid-induced osteoporosis treatment guidelines, the American College of Rheumatology, the guidelines, and you can see the last bullet point, they're all equivocal. So because of limited evidence regarding the benefits and harms of interventions, most recommendations are conditional, uncertain balance between benefits and harms. And then when you look at the data of, and it even says the first bullet, because of limited evidence, most recommendations, again, are conditional. You look at the data on Fosamax and Prolia and Forteo, the first systematic analysis wasn't even published until 2018, and it did not decrease fractures in 9 randomized clinical trials. Prolia, it increased bone density, but it was underpowered to determine if it reduces fracture risk. And Forteo, there's no meta-analysis. It may be more effective according to clinical trials than Fosamax for fractures, but there's no meta-analysis yet. We don't have the strong enough data. From a natural approach, there is a specific form of vitamin K that many people have probably heard of vitamin K for promoting bone health. MK4, it's a specific form of vitamin K2, has had multiple clinical trials of people on prednisone, both adults and pediatric patients. And in the adult patients, the dose of 45 milligrams per day has been shown to stop and reverse bone loss in people taking prednisone. There are no clinical trials in that population looking at fractures. However, there are clinical trials on MK4, 45 milligrams per day, looking at fractures in postmenopausal women with osteoporosis. So SSRIs and SNRIs, I'm not going to spend too much time on this, but the basic mechanism of this results in a 1.6 times higher rate of bone loss. And the majority of serotonin is actually in the periphery. It's not in the CNS. So what happens is there are serotonin receptors on bone, and it stimulates osteoclasts. And so when you are artificially raising serotonin, whether it's an SSRI or an SNRI, you are promoting bone loss. That's the bottom line. Even more, 95% of serotonin is in the periphery. And it actually not just enhances osteoclast activity, but it reduces osteoblast activity. That's the indirect effects on bone. And then peripheral serotonin does act directly on bone. So as I mentioned before, SSRIs and fractures. This one study, for every 42 patients, you'd expect one fracture. And a second study found for every 19 users taking the drugs for 1 to 5 years, we would expect one additional fracture. This is a second meta-analysis. The first study in this slide I'm showing now was also a meta-analysis. So what about SNRIs? I've had conversations with doctors. I've had and patients come to me. They're on SNRIs, and my doctor says it's safe. It doesn't create fractures. It doesn't create bone loss. And I end up having to send their physician, the PDFs and the studies to educate them, to get them to change the medications. So even with SNRIs, we do have a 68% hazard ratio risk for fractures in people with SNRI as well as SSRIs. It's a 10-year Canadian study. Acid blocking medications, 50% of those are written for just acid reflux. And when somebody actually has acid reflux, the risk for fracture, when it's prescribed for acid reflux, the risk for fracture is 349% compared to those people who were not prescribed PPIs, versus as a general population, people on PPIs for 4 years or about 4 years have a 60% increased risk for hip fracture. Now, here's the challenge that I have with acid reflux and the reflexive prescribing of PPIs for acid reflux. For many patients, acid reflux can be effectively dealt with just with dietary changes. There are 5 most common foods that aggravate acid reflux. It's tomatoes, raw garlic, raw onions, citrus, coffee, and chocolate. For other people, spicy foods might be a problem. So, just doing some dietary modifications, finding out if those are issues or if something else is an issue. H. pylori infections can cause GERD. So testing for H. pylori and treating that if it's there, that also may be the underlying cause instead of just prescribing medication. And there's a blog on my website if anybody's interested where I go into those different approaches in some more detail. So as I said, the higher duration, the higher the risk. PPI-induced hip fractures are actually stronger in men, which, I mean, all of it's unfortunate, but it's unfortunate additionally because, as I mentioned earlier, the mortality risk in men with a hip fracture and osteoporosis is about double what it is for women. So when their analysis was restricted to just with GERD, as I mentioned, the odds ratio for hip fracture was 3.49, so 349% greater. In patients with H2RAs, histamine H2 receptor antagonists, it was not significantly associated with increased fracture risk. So look, if they have to be on an acid blocker, it appears that the H2RAs are maybe safer. And there was a meta-analysis also looking at falls and fracture risks in 2019. PPI is significantly associated with increased risk of falls as well, not just fractures, but also increased risk of falls and an increased risk of people who sustained a fall that they would end up in a hospital with an odds ratio of 1.61. So 61% greater risk compared to people not taking PPIs. No significant association with these increased risks in people taking the H2RAs, like Tagamet and Pepcid. So again, that as a category of medications would be a safer choice. Let's talk about bisphosphonates and PPI. So what happens in medicine, as you're all aware, is there's oftentimes not clinical trials. There's not the data to necessarily make decisions off of clinical trials in the patient that you're treating, in the patient population with the same diagnosis, the same medications, the same medical history. And so you go off of clinical guidelines or you go off standard of care. Standard of care, people who were on PPIs and got osteoporosis, was to prescribe a a bisphosphonate, an osteoporosis medication. The assumption was, well, it works for postmenopausal osteoporosis, so let's do it in these other osteoporosis cases as well. And then somebody thought, well, we really should study this, and they did. What they discovered was actually, when you combine a proton pump inhibitor with a bisphosphonate, an oral bisphosphonate, you end up, or just a bisphosphonate, you end up with a higher risk for fracture, 52% increased risk of fracture compared to people just taking bisphosphonates. And it didn't matter which type of bisphosphonate. And to date, there are no published clinical trials evaluating the concomitant use of PPIs with other categories of osteoporosis medications. Look, the mechanism of action for postmenopausal osteoporosis is a decrease in estrogen. The mechanism of action for bisphosphonate-related or PPI-related osteoporosis is different. It's not because of the drop in estrogen. So assuming that just because one medication is applicable to one situation, that it's going to be applicable to another, we see evidence here that we're actually doing more harm than good. So treating PPI-induced osteoporosis, as I mentioned, we've got an increased risk for fractures. And that's a repeat slide. Sorry, that's in there twice. So let's talk about osteoporosis medications as a overarching theme, right? So you've got the anti-resorptive medications. There's the list. You got the anabolic medications, and there's the list as well. The first, Evenity was the first drug approved in about the last 15 years. It was approved in 2017. Now, remember, the most important question to ask about any recommendation is, has it been shown to reduce fractures? So if you look at this, these next couple of slides, so the number needed to treat in this study that pooled all this data and looked at this is for vertebral and hip fractures over 3 years, calculated from the results of randomized double-blind phase 3 clinical trials versus placebo. And the little green box down here that I kind of mentioned before, there's no common universal definition for adverse drug reaction, just like there's no common definition of what polypharmacy means. So the number needed to treat with Fosamax is, alendronate to prevent a hip fracture. You have to treat 91 people for 3 years to get one to prevent one hip fracture. For vertebral fracture, it's better, 14 people for 3 years. And you can go down the list. For risedronate or Actonel, 91 people treated to prevent one hip fracture, 20 to prevent one vertebral fracture. Boniva actually has no hip fracture prevention, is demonstrated, only vertebral fracture. And reclassed, we're talking 90, similar to the other bisphosphonates. You've got 91 people have to be treated for 3 years to prevent one hip fracture, and 14 people for 3 years to prevent one vertebral fracture. Prolia, you've got to treat 200 people over 3 years to prevent one hip fracture, right? Evista does not prevent hip fractures. And again, those are the most dangerous type of fractures. Conjugated estrogen. Now, the bioidentical hormone replacement therapy, there's no clinical trials on it. But the overall effect is saying it's not known. Number needed to treat with Forteo, 200 to prevent over 19 months to prevent one hip fracture. 11 patients over 19 months to prevent one vertebral fracture. Now, those are in clinical trials. But what happens in the real world? Well, in the real world, you've got to have a 70 to 80% compliance to obtain the effect of the drug therapies. But about 50% of people being prescribed a bisphosphonate, they discontinue therapy within 1 year. So in the perfect world of controlled clinical trials, that doesn't really match what's happening out on the streets. And in fact, when you start looking at bisphosphonates and fracture prevention, and you start looking at the clinical trials, I was so upset when I started to really look at the clinical trials, because what's happening in these studies is they're enrolling high-risk individuals who have had a previous fracture, for example. But there's different risks if you've never had a fracture and you're talking about primary prevention versus secondary prevention. And they're not teasing apart the data in these clinical trials with the inclusion criteria, and they're not defining it to that level. And so the data, when you start looking at it, it's very confusing. And so you just get these recommendations of, oh, well, it prevents a fracture. It prevents these fractures. But the reality is they're not equally effective at preventing primary fractures versus secondary fractures. This study, a 2015 meta-analysis, showed that oral bisphosphonates don't prevent primary fractures. Only Zometa, 5 milligrams every 18 months, reduced primary fracture risk. Secondary fractures, for secondary fracture prevention, the medications are more effective. They do work. But the problem that I have is that people are treating a number on a test. Doctors are treating a number on a test. They're sending patients out with these prescriptions that don't work. The doctor is happy because they don't understand. The patient's happy because they don't understand. And we got 2 million fractures a year and people dying. It's horrible. The situation is horrible. And we can all do better. Another more recent meta-analysis, 2020, showed that oral bisphosphonates prevent secondary fractures, but not primary fragility fractures. There's a summary table if anybody is interested. Citations. All right, so let's get to a more holistic approach. So what can we do to reduce people's risk for fractures, reduce people's risk for bone breaking down, and also build bone up, build stronger bone, maintain strong bones, reduce fracture risk? Well, sleep is crucially important. So people who sleep less than 5 hours a night, sleeping less than 5 hours a night is associated with lower bone mineral density and was associated with hip osteoporosis, a 63% increased risk odds ratio of hip osteoporosis, and an increased risk of osteoporosis at the spine. So the optimal amount of sleep for adults is about 7 to 8 hours a night. Most people, as they age, have a hard time sleeping that long. Various reasons for that. Some of it's physiological, some of it's lifestyle. These devices that we all carry around, there was a study that was done a few years ago, people reading on light emitting devices. They're on their screens before they go to bed versus reading just good old fashioned paper. What the study determined is that not only did that deplete melatonin, it made it more difficult for somebody to fall asleep. Now, it only increased sleep latency by 10 minutes. When I read that, I thought, well, okay, that really doesn't sound like a big deal. But what happened in the morning is people who are on light emitting devices prior to going to bed, it took them hours longer to feel awake. And that indicated to the researchers and to me that the participants in the study probably weren't getting into those deeper stage 3 and 4 stages of restorative sleep that we all need for tissue regeneration and for health. There are lots of diseases also that decrease melatonin. So looking at those, you may just need to give somebody some melatonin. Medications that decrease melatonin. Beta blockers decrease melatonin. So they just may need some melatonin. Here's the light emitting devices study I mentioned. All these medications cause sleep disruption. So again, doing a good review of medications and the mechanisms, maybe switching them to different ones if possible, becomes important. With respect to melatonin, though, I do want to say this. So the half-life of melatonin is small, only about an hour. It's short, only about an hour. And so what often happens when people have a hard time sleeping, the first thing they think about is melatonin. And so they take melatonin and it helps them fall asleep because that's the role of melatonin. It has other roles, but that's one of the major roles in terms of modulating the circadian rhythm. And then they wake up in the middle of the night. And then they end up taking more melatonin and more until they take so much, they're knocked out all night, but then they wake up groggy the next day because that's not really the role of melatonin. And after years of looking at this, after years of me, getting complaints from people and asking me to go and do some research and create something, I did that. And I created a product called Sleep Relief. It's the only biphasic time-release delivery mechanism in a sleep dietary supplement on the market. The reason I did that is because sleep is generally in two major categories, right? It's falling asleep and staying asleep. And the mechanisms for falling asleep and the physiology and the endocrinology of falling asleep is a little different than what the body needs to stay asleep. And so the nutrients, a little bit of melatonin, but herbs and amino acids and minerals in that formula in the two phases helps people fall asleep, but then also stay asleep, or if they wake up in the middle of the night, they're not so groggy that they're at an increased risk for falling and getting hurt like they are with benzodiazepines. And then they're able to fall back asleep easier, and it wears off as the night goes on, and they should wake refreshed and ready for their day and not hungover and groggy. That product is called Sleep Relief. There's more information and research studies on my website, nbihealth.com, if anybody wants to learn more. Cortisol, not surprising because we know prednisone and glucocorticoids destroy bone. Even our natural endogenous cortisol destroys bone. Even in normal healthy people, having elevated cortisol has been inversely correlated with bone mineral density. So the higher in women, elevated peak plasma cortisol is associated with lower baseline bone mineral density at the femoral neck and a faster rate of bone loss. So stress management, very important. Sleep as part of stress management, very important. Helping people manage their stress by teaching them to say no, not being overscheduled, getting them into counseling if they need counseling, getting them into doing some self-care, all very important. Connecting with nature, very important. Another supplement for supporting the adrenal glands and modulating the stress response that I created is called Calm and Clear. It's incredibly effective. That's another possible something else that you could use. Social support, not commonly discussed when looking at bone health and osteoporosis. So, but what the research has shown is that it's inversely associated with osteoporosis risk and all-cause mortality, right? That includes dying from a fracture. And it's not just the size of the network, but it's the quality of the social support network as well. A research study looked at how many people in that support network are optimal. And it came out with 3, not 4 or 5 or 6. Having 3 people in a strong social support network was associated with the lowest risk of osteoporosis. And it's not, though, just having the network. You have to actually access it and do things with these people, reach out to these people. And the highest social interaction scores were associated with 30% lower risk of all-cause mortality. In another study, it's not just a lower risk of osteoporosis, but another study showed that people with good social support recovered better when they had a fracture. And so that's important as well. I see some questions came up in the chat. I will get to those at the end, if that's okay. Mediterranean diet and fracture risk. So let's talk about diet. There are lots of diets out there. The ketogenic diet, the alkaline acid diet. The only thing that has the research on it, the body of research showing positive effects on bone, is the Mediterranean style diet. Repeatedly, over and over, frankly, it is the most researched dietary pattern that has, and I don't know of any negative studies, either epidemiological studies or cohort studies, clinical trials that have shown anything negative about the Mediterranean diet in terms of outcomes. Women with higher adherence to the Mediterranean diet had lower risk of fractures. Legumes, wine, fish, olive oil, all were protective. And this supports previous studies also. Meta-analysis, Mediterranean diet is associated with a 21% decreased risk of hip fracture and higher bone mineral density. Higher Mediterranean diet adherence also associated with healthier lifestyle. And this is what we find in the different domains of health. I call it the 4 pillars of health. There's another blog on that on my website, the 4 pillars of health. Diet is one of those. Exercise is one of those. Sleep is one of those. That as people focus on being healthier in one domain, and the research bears this out, as they get success and are feeling better, they tend to also develop healthier habits in other domains of their life as well. So it's a great feed forward system. Other studies reported fewer hip fractures with people following the Mediterranean diet. But what about vegans and vegetarians? Well, they have those dietary patterns have been associated with higher risks for osteoporosis. The speculation is, because not all studies were negative, most of them are, but the speculation is perhaps the reason why a few of the studies that were positive compared to the vast majority of studies that were negative, perhaps in those studies was that vegetarians and vegans aren't getting enough protein. They're obviously getting enough plants and whole foods, but protein seems to be a missing component. And despite even, when I talk to patients and I'm working with them and I do a quick dietary recall and I talk to them about their diet, no matter how adamant they are that they're eating enough and they've got the healthiest diet in the world, when we actually quantify things or look at their diets, almost 100% of the time, they are not getting enough protein. And in fact, 15% of people older than 60 years old are consuming less than 75% of the RDA. So many people aren't even getting the RDA, and the RDA for protein, which is 0.8 to 1.2 grams per kilogram body weight per day, grams of protein per kilogram body weight per day, we now know is insufficient as people get older for maintaining muscle mass. And when you start losing muscle, you can get sarcopenia, you increase the risk for falls and fractures. So what we want to do is increase the amount of protein, or make sure somebody is getting adequate protein. So how much protein is that? Well, the clinical trials, the research is suggesting, at least 1 to 2, and really you're looking at 1.2 to 1.5 grams per kilogram body weight per day. In my book, Fracture Proof Your Bones, there is I walk people through how to calculate how much protein they need to get for their weight. And then there's protein handouts. There's a calcium handout. The other thing I have people focus on is fiber, because that's found in Whole Foods handouts in the book as well. All of these different topics are discussed in the book, and it helps people go through. It helps them create their action plan and helps clinicians understand how they can work better with their patients as well. What about exercise? So 10,000 steps, it's a myth. You only need 7,000 to 7,500. The research shows that you get a 50 to 70% decrease in all-cause mortality when you're looking at 7,000 to 7,500 steps per day on average, and it plateaus at about 7,500 steps. There's a lack of evidence of randomized controlled trials. You need about 7,000 people. High-risk people would be needed to do a randomized clinical trial. But exercise has been associated with reduced risk of fractures by 45%, moderate to vigorous physical exercise. How do you know if it's moderate to vigorous? I like the talk test. Moderate is if you can exercise and have a conversation, but you're a little winded, or you are winded, but you can still carry on the conversation. That's moderate exercise. Vigorous exercise is that you're exercising so much that you can't carry on a conversation. You just can't get the airflow to do that. Balance exercise, muscle strengthening. You don't have to go to a gym. There's things I've looked at Qigong and Tai Chi. I love the stork exercise actually for balance. I teach people this all the time. I like simple solutions, practical things people can do in their home, work into their daily lives. The stork exercise is fantastic. It's just 2 minutes twice a day. Storks, they like to stand on one foot. So I like the imagery. And essentially, I'm backing up here so maybe you can see, while somebody's brushing their teeth in the morning, they stand on one leg. You can't see my right leg is up, and they're brushing their teeth. They need to steady themselves. They can steady themselves on the counter a little bit. And then when they go to the top teeth for the second minute, they switch feet, right? They switch legs. And over time, that works some of the core muscles, some of the smaller muscles, and it can improve their balance. Now, when that becomes easier, you can have them actually switch to their non-dominant hand to brush their teeth. And that would also throw a little bit of a challenge to their nervous system so they can get a little more benefit from that. So I like this exercise and diet consensus that came out of Europe. It's the only one that I found to date that actually incorporates exercise with protein. And this is what they're recommending in terms of protein. I like the upper, I don't like less than 1.2. That's the minimum for me. 1.2 grams per kilogram body weight per day, at least 20 to 25 grams of protein with each main meal. So that's another way to look at it as well. So let's talk about nutrients, dietary supplements, individual nutrients. So the ones at the top, those are the ones that have been shown to reduce fractures. The ones at the bottom, they've not been shown to reduce fractures, but a couple of them, like collagen and melatonin, do have some emerging compelling research on them. I'm going to jump right to magnesium quickly because that's a real urban myth that magnesium, is good, reduces fracture risk. It doesn't. There's one clinical trials in the 1990s that showed that magnesium as magnesium oxide actually helped improve bone density, but it never looked at fractures. There are no studies showing that magnesium reduces fracture risk. And the bulk of the evidence is the opposite in terms of magnesium intake, that actually magnesium intake has been concluded over and over does not reduce fracture risk. Now, I love magnesium. It's an important nutrient and most people don't get enough, but specifically when we're talking about bone health, we're talking about reducing fractures. I believe a targeted approach, because that's what we're looking at, is better. In a good multivitamin or for other reasons, having magnesium is important. So calcium and vitamin D, what we're really looking at, calcium and vitamin D, may reduce fractures by about 10 to 23% in combination. Calcium citrate is one of the more absorbable forms of calcium because it doesn't require stomach acid. As people get older, or if they have autoimmune diseases, or obviously if they're on an acid blocking medication, they have lower stomach acid, so their pH is higher in the stomach. And so calcium carbonate can't get dissolved. You can't disassociate the calcium from the carbonate. And so the absorption goes down, whereas the pH for calcium absorption in the calcium citrate is about 7.5, is a higher pH, so above 6.5. So it's absorbed in the ileum, even when there is low stomach acid. So how much vitamin D do you need? I'm a fan of testing vitamin D and tracking vitamin D. The research shows in terms of an association with fracture risk, optimal fracture risk reduction is achieved with the mean serum vitamin D of 30 to 44 nanograms per milliliter. If you're looking at immune boosting effects of vitamin D, you're looking at higher, 50 to 60. I just did a research review for the Natural Medicine Journal. It's called an abstract and commentary, or a review of a clinical trial looking at vitamin D in hospitalizations in people diagnosed with COVID-19. And it appears that overall, you're looking at wanting to get that vitamin D level above 50 for the immune stimulating benefits when it comes to infections. When it comes to just bone health, 30 to 44 nanograms per milliliter is associated with the optimal fracture reduction. When you're looking at fall prevention, also 30 to 44 nanograms per milliliter. But if you're looking at bone density, and this goes back to the bone density story of how it's not that great of a surrogate marker, that you get a higher bone density when the vitamin D is 9 to 37.6 nanograms per milliliter. But if your vitamin D is 10 or 20, and a clinician saying, well, that's great, you're fine, you're not actually in that range where it's protective against fractures and falls, because a bone density test, again, is a poor predictor of fractures. U.S. Preventative Services Task Force recommends against routine vitamin D supplementation to prevent falls in the elderly. I recommend people test for vitamin D and dose and appropriately to get people's vitamin D into the healthy range. Safety, calcium safety has been an issue. There have been quite a few studies that looked at this. The consensus at the moment is that calcium supplementation up to 1,000 milligrams per day is safe. Dietary supplements really should be a supplement to a healthy diet, as the FDA intended, not to replace diet. Routinely, doctors are recommending 1,200, 1,500 milligrams of calcium as a dietary supplement, and that's inappropriate. because it should take diet into account. The USRDA for calcium for women, for adults is 1,200 to 15 milligrams per day. The average American woman gets about 800 milligrams of calcium per day. So 400 milligrams of calcium as a dietary supplement should be sufficient for most women to get them into that healthy range. And the position statement of the National Osteoporosis Foundation, which is now the Bone Health and Osteoporosis Foundation, they rebranded, the American Society for Preventive Cardiology, is that the combination of calcium from all the different sources should not exceed 2,000 to 2,500 milligrams per day. That is considered safe from a cardiovascular standpoint. And so that's the position that I'm going with as well, also based on my reading of the clinical trials and the meta-analyses. So let's talk about vitamin K. Osteocalcin is another surrogate marker that's often tested by clinicians who do functional medicine. All forms of vitamin K, there's vitamin K1, phyloquinone, found in green leafy vegetables. Vitamin K2 is a category of nutrients that includes different subtypes of vitamin K2. The ones found in dietary supplements are typically MK7 or MK4. All forms of vitamin K will decrease osteocalcin. But the question is, have any of these forms of vitamin K been shown to reduce fractures? And first of all, if you're testing osteocalcin, I would really recommend you think twice about using that blood test. The reason is there tends to be an oversimplification, I think, when it comes to many complex diseases, osteoporosis being one of them. And in this case, osteocalcin is a protein. And I mentioned before, there are about 200 non-collagenous proteins in bone. And if you're just testing osteocalcin, boiling it down to just one surrogate marker, one protein in bone, you're missing the bigger picture, which is maybe why the osteocalcin as a surrogate marker is really not a great predictor of fractures. And it has systemic effects. It's actually now considered a hormone. It increases insulin secretion in the pancreas and beta cell proliferation, stimulates adiponectin genes in adipose tissue to enhance insulin sensitivity. It binds to Leydig cells to enhance testosterone synthesis, and it inhibits GABA synthesis to help improve learning and memory. The causal effect is not supported when you look at the animal studies, right? There are no clinical trials that have said, okay, we're just going to change this one marker and with the vitamin K and look at fracture. Now, there are clinical trials that use vitamin K and looked at fractures, and I'll talk about that. But they didn't test osteocalcin at the same time. When you look at clinical trials, animals who were bred to be deficient in osteocalcin actually had stronger bones at 6 months than animals that had normal osteocalcin. A review of osteocalcin cautioned against interpreting it for bone health, that it should be considered a marker for vitamin K status more than a marker for bone health. All right, so let's look at fractures. The only form of vitamin K that has been approved by any government entity for bone health is MK4, 45 milligrams a day. Since 1995, the Japanese 2011 guidelines state metatetrenone is the name for MK4, is considered to exert its fracture-reducing effect via mechanism action other than increasing bone mineral density. So again, go back to the story of bone mineral density. It's a more complicated story than just looking at bone density, all right? So the mammals have the enzyme to convert vitamin K1 to MK4. MK4 also accumulates in tissues throughout the body, not just the bones, but the testes, the pancreas, breasts. It's used for sphingolipid production, which points to many other potential beneficial effects of MK4. Like all nutrients, magnesium included, other nutrients typically have many roles in the body and have other beneficial effects as well. MK7 is not created by humans. It's created by bacteria. It has a longer half-life than MK4. It's more bioavailable than MK4. And therefore, there are studies out there and companies that are promoting MK7 showing it promotes bone mineral density, which it does. It's been shown to help enhance bone mineral density. It has a longer half-life and it's more bioavailable. Therefore, it's better than MK4. But they're missing the most crucial question. And unfortunately, consumers out there, and we need doctors to help interpret this for people. The most important question is, has MK7 or any form of vitamin K ever been shown in clinical trials to reduce fractures, which is the ultimate indicator of bone strength? The answer to that is only MK4. MK7 has never been shown in clinical trials to reduce fractures as the endpoint. In clinical trials with MK4, 45 milligrams a day, these are the different patient populations that have been tested. People with anorexia nervosa, osteoporosis caused by these different issues, glucocorticoids I mentioned before, disuse from stroke, leuprolide, postmenopausal osteoporosis, et cetera. A study, and this really fries me because this study, I saw it in the North America Menopause Society, and some updated recommendations they came out with. They used this study to say that vitamin K does not reduce fractures. And I've seen this recently in another study. It really upsets me, similar to the studies on the efficacy of medications being mischaracterized. This study is being mischaracterized because the authors of the study even say, and this is a quote at the very end, bolded, the results cannot be confirmatory with regard to the relative effectiveness of different forms of vitamin K regimes. So different vitamin K regimes. What happens is you see it in the literature all the time. They just say it's vitamin K. I've had to actually email researchers and say, which form of vitamin K did you use? Because they're not the same molecule. And as we all know, in biochemistry, if you change one atom, you can get different effects. Sure, it's a Venn diagram. There's overlapping effects, but they're not all the same. In fact, MK4 is the only form of vitamin K that's been shown to have anti-cancer benefits. One of 4 of the orphan drug designations that I've received from the FDA are for the use of MK4 for the potential treatment of acute myeloid leukemia, myeloid dysplastic syndrome, hepatocellular carcinoma, and promyelocytic leukemia, all based on published clinical trials up to phase 2 clinical trials, and in the case of promyelocytic leukemia, based on a case report. So that's all in the public domain out there. MK7, vitamin K1, haven't been shown to have any anti-cancer effects. And let me just state for the record, these are dietary supplements. They're not approved by the FDA to diagnose, treat, prevent, or cure any disease, but they can promote health, and the clinical trials show it very convincingly. With respect to vitamin K, though, if you look at the different forms of vitamin K and the meta-analyses on it, the picture becomes clearer. So dietary vitamin K1, what we see is that there's an inverse association with intake and the risk of fractures from diet, right? So, and for each increase of 50 micrograms a day of vitamin K1 from the diet, you get a 3% reduced rate of fracture. But there aren't any clinical trials of vitamin K1 as a dietary supplement with fractures as the outcome. Here's a first meta-analysis of MK4. Now, I can't present to you any meta-analyses of MK7 for fractures because there are no studies that have had fractures as the primary outcome. Now, to be fair, yes, perhaps MK7 may reduce fractures, but the data aren't there. And so from my point of view, making clinical decisions, if there are data showing, especially from multiple clinical trials over many years in different populations, showing the clinical benefit that I'm going for, that's what I'm going to recommend. And in fact, that's why I created my products, OsteoK and OsteoK Minis, because the clinical dose of MK4, 45 milligrams per day, didn't exist in a dietary supplement. And so I created it and combined it with vitamin D and calcium. The only difference between the two products is the amount of calcium. The OsteoK Minis has 400 milligrams of calcium per day. The OsteoK has 1,000 milligrams of calcium per day, depending on how much calcium somebody needs as a dietary supplement. Both products provide 2,000 IUs of vitamin D3 and 45 milligrams per day of MK4. I'm so convinced by the data on the MK4 that recently, and 16 years of working with this nutrient and these products, the product came on the market in almost 16 years, 2007. that we recently rolled out a guarantee called the Strong Bones Guarantee, that if not only will we guarantee that somebody's bone density will stabilize or improve within 6 months of taking either of the products, but if they break a bone, we guarantee that it will maintain bone strength. And the best indicator of bone strength is breaking a bone. So if they break a bone while taking the product, we will refund their money for all qualifying purchases between their bone density tests. Now, I have to keep having bone density tests. I do think, despite the limitations, that's an important test to continue to do. MK4 meta-analysis. MK4 meta, here's the first one, 2006, showed a reduction. So there were 2 studies after this was published that were retracted. But fortunately, the researchers already did an analysis of a subset of the data that excluded those studies. So that's already in the original 2006 publication, Table 3, and I believe it's Table 3. And even with those studies excluded, you still had a 60% reduction of vertebral fracture risk and a 76% reduction in all non-vertebral fractures. A 2015 meta-analysis with 7 studies reporting fractures, all used 45 milligrams per day of MK4. You're talking about a 53% reduction in fracture incidence for people taking MK4. And so I'll just leave that for now from that. Safety, there's no tolerable upper limit set for vitamin K. Human coagulation studies go up to 135 milligrams per day of MK4, showed no significant increase in pathological coagulation risk. And in rats, talking about 250 milligrams per day, per kilogram body weight, did not alter any risk for blood clots. One caution with MK7, if you do end up using it, people with celiac or gluten intolerance are at elevated risk for soy allergies, and MK7 is derived from soy. I'm not going to go into, here's all the strontium stuff, but I already talked about the risk with strontium. This second bullet here, summarizes a quote from the study. Basically, the number of fractures prevented by strontium is similar to the number of extra cases of venous thromboembolism, pulmonary embolism, and MI caused by strontium. And here are the clinical trials on strontium ranelate. It repeatedly showed an improvement in the risk for vertebral fractures, but most studies actually did not show any reduced risk in hip fractures, except for this one, the first bullet point there at the top, and the second bullet point, or only the second bullet point. So only one of those 6 trials showed a reduction in hip fracture risk. Let's talk about collagen as a dietary supplement. 90% of collagen in bone is type 1 collagen. The rat study showed that femoral fractures healed significantly faster when they were fed hydrolyzed collagen. Similarly, fractures, experimentally induced fractures in animals did heal faster when MK4 was actually given to them as well in another animal study. Collagen and CTX. So if you test CTX, collagen has been shown to reduce CTX. CTX is a breakdown product of specifically of collagen. It is associated with an increased risk for fractures. In this study, when it was combined with both a low hip bone mineral density, you had an increased prediction of relative risk for fractures as well. When estradiol was low, you also had an increased risk relative to if it was just the highest quartile of CTX. So there was a clinical trial again of collagen. It decreased the CTX by about 11.4%. And the International Osteoporosis Foundation, the International Federation of Clinical Chemistry and Laboratory Medicine do recommend serum CTX as a reference marker for use in fracture risk prediction and for treating osteoporosis treatment monitoring. A benefit of that is that these bone turnover markers can be tested more frequently than a bone density test. So it can be useful for monitoring response to treatment or continuing these conversations with patients. Magnesium, I mentioned magnesium before. So I'm not going to belabor the point. Significantly lower concentration of serum magnesium in osteoporotic women compared with controls. Bottom line, hypomagnesemia is associated with lower bone mineral density. But in terms of fracture risk, prospective cohort study, there was no evidence of an association of dietary magnesium intake with risk of any fractures. And that was in 2 studies, the Women's Health Initiative data as well. And there are no prospective clinical controlled trials that have shown magnesium reduces fractures. Melatonin, there's an intriguing study recently with melatonin showing, this is in women with osteopenia, showed that it actually improved in a dose-dependent manner bone density. So there is no clinical trial showing fracture as an endpoint, but it did improve bone density. Boron, no studies, no clinical trials supporting boron at all in the dietary supplement for osteoporosis or for bone health. And there are no studies showing that improves bone mineral density, decreases bone loss, or decreases fractures. Soy isoflavones, the same. There's some observational studies and clinical trials have not shown any consistent evidence that soy isoflavones build stronger bones. And here's my conclusion. Keep it simple. Focus exclusively on reducing fractures. That's the most important question. And it really is not more complicated than that. Don't ever overemphasize the usefulness of testing. Don't rely just on these surrogate markers. Maximize diet and lifestyle. And for dietary supplements, again, keep it simple. My first line is Osteo-K or Osteo-K minis. And then the second line would be the collagen peptides, melatonin, or my sleep relief product if indicated, because they're having problems sleeping, as well as other lifestyle factors, trying to identify other ways you can help them with sleep. There's a blog that has a checklist for sleep on my website. I also go into it in detail in my book, and then dealing with stress and all the other factors that I mentioned. Third line, everything else based on client need and patient need and clinical indicators. And that's the end.
Wow, great. Thank you so much, Dr. Neustadt. That was fabulous. So I love these talks because, I learned so much. A lot of my education came from, at least in this area, came from A4M, and A4M was really high on CTX testing for osteoporosis and strontium for, as sort of a first line remedy. That's what I was taught. And that's sort of what we've been going by. So that's why, these webinars are really invaluable. And, I know Dr. Halas is on now. He's still at A4M, or he just came back from there.
I spoke years ago at A4M on osteoporosis. I would love to speak there again as an update. It's been, I think, over a decade. I would love to give an update on the research. With strontium, one other thing that's important to know, if people are using it, because it incorporates into bone and it's heavier than calcium, strontium also gives false bone density test results. So that's important to know, that yes, it improves bone density, but the test result you're going to get is not accurate.
Okay. So everybody knows, who knows me here knows I'm the hormone guy. So other than estrogen, any hormone balancing or replacement that you recommend for bone density or reducing fractures?
So that is a great question, and I'm going to punt on that because I am not an expert in that field, and I haven't looked closely enough at the research on that. I do, I think there are strong cases for getting hormones and keeping hormones in the physiological, range. But in terms of looking at fracture risk and bone density, I've got a punt on that question for a little later, so I can finish my review.
Just one comment on boron. Now, we'll respect the data that you showed us. However, boron reduces sex hormone binding globulin, which will increase testosterone. And testosterone, that I know in my research, will increase bone density by up to 5 to 7% in certain instances. So it may be an indirect effect, not a direct effect.
So, and I think that's great. But if you're just looking at osteoporosis, if you're looking at maximizing hormone replacement therapy, then that is, could be an indication for it. The question I would have is, has testosterone been shown to reduce fractures? And boron should be in a good multivitamin anyway, in my opinion.
Right. Okay, 5 milligrams is the dose, by the way. Just in
Okay.
case.
Good to know.
And again, we use it for to lower sex hormone binding globulin if it's very high and their free androgen index is low. I call it an indirect effect. So there's a couple of questions in the chat, and this first one is, what is your opinion of, and I never heard of the Siscius quadrilangaris leaf for severe osteoporosis?
I've never heard of it. I mean, I would ask the question, are there clinical trials showing that it reduces fractures?
Right. Okay. Well, that's the question of the night, of course. And again, I haven't heard of it either. So,
okay.
So, Dr. Fishbein, if you're on still, if you could chime in here, maybe.
I mean, when you're looking at the research and you're talking about a 76% fracture reduction just from the MK4,
Right.
vitamin D and calcium, and then you've got all the other lifestyle and all these other things.
Well,
that's where clinically, everybody's going to make their own clinical decisions, but that's really where
but as you know, I'm sure you know too, we all have our own, sort of favorites or things that we've been steered toward. And like I said, strontium was what we were taught at A4M, and you pretty much blown that out of the water. So I want to thank you for that, actually.
Oh.
And another question here, and we've had a lot of discussion on photodynamic therapy, red light therapy, and any use for that in osteoporosis?
I don't know of any studies in osteoporosis with
Got it. Okay.
With red light therapy.
Okay.
Well, I think Dr. As Dr. Hanessa, how are you? Dr. Bill.
Yeah, great.
I'm in Vegas here. Can you hear me, guys?
Mm-hmm.
Yes.
I'm still in Vegas, yeah. So anyway, I'm in the sauna here. They have something called Ranch, and they have a nice spa. And this is my first time, although I'm being in Vegas in Venetian for every year, I think. But yeah, I know we want to talk about osteoporosis, and I'm a little bit leaning to oxytocin. I think that's the trend. And there is more than couples of publications that show the connection or the treatment of oxytocin for bone density. But we need more clinical data, not just the publications. So injecting 2 international units around the umbilical per day, possibly intranasal oxytocin altogether, and see how that will affect the bone density. That would be something new. I mean, there is published, but if we can get more clinical from you guys, that would be great.
Great information. Thank you.
We can put your society on it, Dr. Halassa. Dr. Horvitz says, the supplementing with 5-HTP, which increases serotonin, increase the risk of bone loss.
So there are no studies that I know of that have shown any association with 5-HTP and bone loss. If somebody is concerned about that, you can supplement with L-tryptophan instead, because the rate limiting step is that conversion from L-tryptophan to its downstream products. But I haven't seen any studies showing any problem with bone loss and 5-HTP supplementation.
Okay, good. Another question a little bit. So baking soda that promotes osteoporosis like the PPIs?
I've never seen any research showing that that's the case.
Okay. Anything on things like zinc carnosine or deglycerinated licorice? Any information on either of those? Because those are the other things we'll use for reflux.
Oh, I think DGL is great for reflux. Yeah, DGL is great. Besides just dietary changes. Marshmallow is great. The herb for soothing. You get some emollient sort of actions in the mucosa in the esophagus for kind of soothing the tissue. But yes, DGL is great.
Mm-hmm. And of course, we have our jolly joker here. Should we dim the video during the lecture to prevent bone loss as it's dark on the East Coast?
So to be fair with the study, they read for 4 hours. So, is it dose dependent depletion of melatonin? I don't know.
I don't know either. Now this is either a question or a statement. I'm not sure. IV vitamin C helpful?
For osteoporosis, I've
yeah.
never seen any data one way or the other.
Is osteocalcin and telopeptide reliable blood tests?
So CTX in urine or blood is reliable. They do have an osteocalcin. All of them have, but the bone turnover markers have diurnal variations. The CTX tends to peak in the morning. I believe the osteocalcin as well, although I'm not certain on the time of day. The most important thing, though, is to just test at the same time repeatedly. Is what the recommendations. First morning is best, but even better is just to make sure you're repeating the test at the same time. The other test I didn't mention is the neutrophil to lymphocyte ratio. There's a good, strong association between an elevated neutrophil to lymphocyte ratio in one study and osteopenia and osteoporosis. So that's another, CBCs are common, they're standard, so you can just easily calculate that.
How big a ratio?
The neutrophil to lymphocyte ratio associated with osteoporosis was above, I think it was 3.17, and for osteopenia it was in the 2s. I could pull that up.
Because I mean that's usually indicative of some sort of
inflammation.
Inflammation.
Yeah, I think that reflects interleukin 6 when you have neutrophilia and a shift to neutrophilia. This means there's interleukin 6, so which means that there is any study that shows osteoporosis and interleukin 6 relationship?
I've not looked at that question, so I don't know.
Do you believe in increasing muscle mass in adults also increases bone health?
So I don't know of a study that looked at muscle mass and bone health. And by bone health, they'd probably be looking at, in the studies, they probably would have looked at bone density. What we do know is weightlifting exercises, resistance training is associated with improving bone mineral density. But they didn't, I don't know of any studies that also looked at the muscle mass as one of the variables that was evaluated. What we do know, though, is that, that anything you can do to increase your muscle, it can increase strength and balance, reduce falls, and reduce those risks.
Okay. Would a carnivore diet of whole natural foods be of any assistance?
Would a carnivore
increasing protein, I suppose, right?
Would a more so the research seems to support an omnivore diet. So getting adequate protein while really having what would be considered a more plant-forward diet, making sure that you're eating enough whole foods, but also getting enough protein. When you're talking about whole foods, like the Paleolithic diet, our ancestors ate about 150 grams of fiber a day. In our society today, we're maybe getting 15 or 20 grams on average a day. So I try and tell people, look, just get up to 30. Get to 30 grams a day from whole foods. That's going to have the plant vitamins and minerals and other phytonutrients to help. And it's the overall dietary pattern. Again, that Mediterranean style diet, which is more of a plant forward type diet with lean proteins, with legumes and whole grains, that has been consistently associated with better health outcomes.
Okay. A rhetorical question here. Can we truly rely on government recommendations for these nutrients?
Truly. I think we can truly take them with a grain of salt, and I'll try and look at the data ourselves.
Yeah, I got a nope and a ditto here. Okay, so that next one was mine. Dr. Hartman says MK677, which is growth hormone. It's an oral form of HGH. It's a peptide. It's a precursor. It's a precursor of growth hormone.
I've never heard of that. I've not used it. I've not looked at the research on it.
We
If
actually
there's
use it
research on
quite.
osteoporosis. I would love to.
Yeah, we actually use it quite a bit. Anyone in the group is a pediatric rheumatologist? There was a question. Have you heard of OsteoStrong and or studies that show them, and also their use of red light? I think OsteoStrong is some sort of vibratory type of sort of passive exercise. I'm not sure.
Is that the one that has the vibrational plates? It's
I think that's what it is.
Brick and mortar business where they
right.
go. We have one actually not far from me. I'm in San Diego, and I went in. It's a franchise model. I talked with the owner. I asked to see the studies. They have some studies on vibrational plates and bone density, but no studies looking at fractures. Now, look, maybe it works. I'm all for anything where, that's also increasing balance and some strength. So I don't think it's a bad recommendation. I can only, I can only say what the research is showing. And
hey, doc,
that's something, and it's about meeting people, I think, where they're at. And if they want to go into a place and they want to do vibrational plates and they want to do things to, and that's where their interest is, I'm all for it. It's not, I don't think it's bad.
It's Joel.
Hi, Joel.
I did it for a little while. They have bioresonance. They have a vibrational massage table. They have PEMF mats. And then they have cuffs with air that squeezes the extremities. And then they use 4 different machines where you use anywhere from 10 to 20 seconds of the most amount of strength you can push, pull, lift, and do legs. And supposedly Tony Robbins has gotten involved with them.
Yeah, he's one of the funders.
And they're showing some great results on top of the vibration plus the strings. So most of their people are women.
Yeah, I think that sounds fantastic. I mean,
it's something to look into.
Great.
Yeah, I think one of the issues, though, it's kind of expensive, isn't it?
Yeah, as a veteran, I was paying $200 a month, and that included a full, and actually, I'll be honest, I want to go back. It included a full infrared light plate that was almost 5.5, 6 feet tall. And I felt great when I was going through it. It was actually amazing, to be honest.
Oh, that's great.
Okay. So this now we're on the other side. The question is, what heals fractures? A friend sent his mother for hyperbaric oxygen therapy.
I'm not familiar on the data on hyperbaric oxygen. I do know that MK4 and collagen have both been shown in animal studies to heal fractures. There may be other things out there. I'm just not aware. It's a huge topic, and as you guys are bringing other ideas to the the table here. I mean, there's so much to look at. We have, our group is, we have medical doctors, we have physical therapists, we have naturopaths, we have chiropractors. We have a little smattering of everything. So everybody has their own, sort of little likes and fiefdoms and things like that. So early in the late 90s and early 2000s, I was in a big insurance-based medical group before I saw the light, and we were one of the things we were graded on was did we prescribe enough bisphosphonates per 100 patient visits. That was one of the things and I remember they would have to drink a whole glass of water and sit up for 30 minutes. I think once a week for the Fosamax ones, and then Boniva wasn't it? Sally Fields was selling Boniva, I think, which was a once a month one. And then now I don't hear too much about them. So, so are you still recommending them at all, or now do you see clinical patients? So I only do pro bono consulting now. I'm not in a clinic. I'll people contact me and doctors around the country and patients, and I'll review labs, and I'll I'll send people back to their doctors, say, ask this question. Have you thought about this? I will give lifestyle, dietary supplement, recommendations. I'll say, try, you should have, this test, test X, Y, or Z you're missing, ask for that. But when it comes to prescribing medications, I don't prescribe the medications, even if I were seeing patients right now, because that's just not I frankly, I don't want to be managing medications would be really the reason. If somebody had secondary osteo, if that already had a fracture and we're looking at secondary prevention, that there is an argument to be made for the medications. I believe it's a real question about informed consent. And that's where I think our colleagues and our profession as a whole does a very poor job of really explaining the potential risks and side effects and giving people enough information so that they can make an informed decision. And one of the things I go to great lengths at in my book is educating patients of what questions to ask their doctors so they can get the information so they can make the best decision for themselves. So my position is more trying to educate patients, and it's their decision whether or not they want to take the medication.
Mm-hmm. Okay. Well, great. Okay. So again, and sometimes we don't know right away, when those bisphosphonates came out, that they were all the rage. And then 10 years later, we get this information that, there's people complaining that their teeth are falling out. And it actually caused osteoporosis or osteomalacia of the jaw or something.
Yeah. So
why would it go to that bone?
So actually, I wrote an article on bisphosphonate-related osteonecrosis of the jaw for a dental medical journal. And the thinking, what happens with bisphosphonates, at least in vitro, is it reduces collagen production, reduces connective tissue production. It also, what happens because there's so much pressure in the jaw when they're chewing, you end up with micro cracks, micro fractures in the jaw that then don't heal. And it creates a space when the barrier, the mucosa is broken, when a tooth extraction happens, for an infection then to invade the jaw. And then you already have a situation where the healthy bone remodeling has been poisoned. And so the bone can't repair itself, and the infection is already in the bone, and it just starts to dissolve the bone.
Okay. Great. Okay. Anybody else have any comments or questions? We always like a quick summary before we let you go for the rest of your day.
Well, thank you.
So
the summary I would say is keep it simple. I think I would go back to this last slide, that there are lots of things you can do, and they may be great clinical strategies and absolutely appropriate. The hormone replacement, the boron to lower SHBG, all of those things may be fantastic. From my point of view, I think it's important though to ask the question, has this been shown to reduce fractures? First and foremost, just so has what you're recommending actually been shown to have the clinical outcome that you want? If it's changing the number on a test, a surrogate marker, I think we can all do better, because that doesn't necessarily translate into lower fractures. So there is a place for changing surrogate markers, absolutely, as part of potentially an overall approach. But at least from my point of view, the first line therapy should absolutely be recommendations that are shown in clinical trials to reduce fractures.
Okay, terrific. Thank you so much for your time. This was truly fascinating. Please come back another time.
Thank you.
I'm sure we're going to have lots of questions in the future. Anybody who's new, we will put the video and we have Dr. Neustadt's slides on our website. We always do a transcript also. It's on aosrd.org/webinars. We've been here for over 2 years doing this, and we're sort of just getting started. Anybody who wants to present anything, please let me know. I have endless Tuesdays to fill up, and we're always looking for folks like Dr. Neustadt, who I'm not even sure how I got your name. I got it from somebody, and just absolutely fabulous. And again, if you Dr. Halassa, you're at A4M, you know, a lecturer like Dr. Neustadt, you'd pay a lot of money to go sit and listen to this. And, you know, we get them here for, we just twist their arm. That's all. We try to be nice to them.
You're great.
Where can, so the Osteo-K and Osteo-K minis,
Right.
What makes them unique versus, you know, just going over to, you know, Walmart?
So Walmart, you won't find the MK4 in the clinical dose.
Mm-hmm.
You definitely won't find it at all. You won't find it with calcium and vitamin D. So it is a bone support product that has, it's basically all in one. Now, multivitamin on the side for other, you know, supportive nutrients may be a great choice as well. But when we're talking about just for reducing, maintaining strong bones, as indicated by reducing fractures, it has the nutrients in there shown to reduce fractures by more than 70% in those products. And that's all that somebody needs, that the research has shown gets those results.
Okay. We can get it at nbihealth.com.
nbihealth.com, also distributed through Emerson Ecologics and Fullscript and Dr. Supplement Store. And yes, nbihealth.com as well.
Okay. What is
the
Osteo-K Mini? What is that?
Osteo-K Minis is just a variation of the product that has less calcium. So let me go back up here and show the bottles. So the Osteo-K, both Osteo-K and Osteo-K Minis provide 45 milligrams per day of MK4. And we only use 98% pure MK4, by the way. If you look at the raw materials world of dietary supplements, there are two types of MK4 that are available, 1% MK4 and 98%. So the 1% means it's cut with other stuff. So we only use 98% pure, and it's really, they can't say that it's 100%. It just, you know, that's the limit that they're able to say. But it's pure MK4, 45 milligrams a day, and then 2,000 IUs of vitamin D3. And the Osteo-K has 1,000 milligrams of calcium as calcium citrate per day. And the Osteo-K has 400 milligrams of calcium as calcium citrate per day. Because there's less calcium in the Osteo-K minis, the capsules are smaller, thus minis, thus the word minis, and there are fewer of them. So the Osteo-K, the recommendation is 3 capsules twice a day with meals. And the Osteo-K minis is 2 smaller capsules per day, twice a day, 2 smaller capsules twice a day with meals.
Okay. What's the cost on these?
$38.87 wholesale, $64.95 retail. Okay. But I do think with inflation, I think we've had costs go up. I think after the first of the year, we're going to increase, I think, by $1.
And you do have like wholesale accounts?
Yes, we have wholesale accounts and quantity discounts. So 10% off if you order 12 bottles of any combination of MBI products, not just Osteo-K. You automatically get 10% off. And then 36 bottles or more of any combination of products, you automatically get 15% off. And then we do run sales at different times of the year that are eligible for wholesale accounts as well for another 10% off.
Okay. Give us heads up on the sales. We will let our folks know.
So. Oh, thank you. And sign up for our newsletter because we announce the sales in there, but I will let you know as well. We also have, if people do have affiliate programs on their websites, we do have an affiliate program as well.
Great. Again, I can't thank you enough. This was really, truly fascinating. And like I said, it's a topic that I don't really spend a whole lot of time on, but I see I should. And I hope everybody, you know, that's still here is equally as, you know, has equally, you know, newly informed. Next week, we have Dr. John Swartz. He does the biophoto scanner. It's one of these things where you put your hand on some light thing and it tells you what's wrong with you, I think. I mean, that's my understanding of it. So he'll explain it. So I'm not sure how that works, but he'll explain it. Everybody have a, you know, whatever holiday season is that you're, you know, that's in your heart or in your family, please have a safe and happy holiday season. Thank you for being here. Thank you for your support. You don't know this, Dr. Neustadt, but we've had quite an upheaval this year. The AOA has decided that we were not worthy of them, and they decertified us. So we're in a battle. So, but we're still here. At the end of April, at the end of January 22nd to the 26th, I think, the Nevada Osteopathic Medical Association is having their winter conference at Lake Tahoe. And we've been asked to do some presentations. So if anybody is in the area or wants to come to the area or wants to go skiing, let me know. And we have about 8 hours that have been reserved for us that we can present. And the CME credits will go through NOMA, since we're not allowed to give them anymore for the DOs anyway. So anybody who's interested in that, let me know, and we'll get you on the schedule. Other than that, we'll let you know about future events. Anybody that has any questions, comments, anybody who has anything that they'd like to present, as you can see, we're non-CME, so we're able to do the brand names. We can talk about your products without the CME restriction. So, it's a double-edged sword. No credits, but we get to find out about things like Osteo-K minis. So,
yep. And we have other NBI products as well that are available.
All right. So it's NBI
health.com.
NBIhealth.com.
Yep.
And I'll mark that in the chat, NBIhealth.com. Dr. Neustadt, I can't thank you enough. And you sent me your book, and it's I read it from cover to cover in 2 nights. So
wonderful.
And I have it on my desk because I realized that this is an area that I've sort of been remiss in. And Joel, they're right under you, can vouch for it because he's.
And the books are also available wholesale through my website as well. There are clinics that are starting to carry them and sell them to their patients and finding.
Hey, Doc, Dr. Neustadt, I'm on your site right now, and
yes, sir.
For some reason the newsletter link's not working. Just thought I'd let you know.
Really?
Yeah. At least it's not on an iPhone. I could try it on the iPad.
Oh, it should. Sorry about that.
Yeah.
All right.
We've had all sorts of defective things here. This is I think second or third week in a row we've had trouble just starting the Zoom call, and I don't know why. So again, everybody, we were a little bit late because I was having trouble getting the Zoom call together. And thanks for sticking with us. So we'll have everybody.
If I just may, if anybody is having a problem signing up for the, sorry, if anybody's having problems, signing up for the newsletter, here it is. It's showing up here on my laptop. Just let me know and shoot me an email, and I'll make sure you get on there. But there should be a pop-up.
It worked. It worked great on the iPad, but not the iPhone.
Got it. Yeah. Okay. So iPad and desktop should work just fine. Thank you for that. I'll let my team know.
Definitely.
And I'll test it out. We'll test it out.
Anybody else have anything? John, you got anything for us? You always have words of wisdom before we leave.
Yeah, just words of praise for a nice show tonight. Thank you very much.
Thank you so much.
Okay. All right, everybody. Have a lovely holiday season. We'll see you again next week, same time, same station. And like I always say, bring one friend and we will double our census. If everybody brings one friend. Okay. Okay. Thank you so much, Dr. Neustadt. Again, we will badger you to come back. You can bet on it. Okay.
Thank you. I would love to.
And we are here every Tuesday night if you're interested in any of the other topics that we deal with, which is pretty much anything integrative.
Hey, Doc.
Yes, sir.
Dr. Clearfield, actually, since I'm a jarhead, I'm kind of curious what Dr. Hartman keeps wheeling along there, and he's sewing. Looks like a gun apparatus. Yeah. I'm just saying.
Yeah, this is a stringing machine. It strings tennis rackets.
Oh,
Yeah.
should have guessed. I should have guessed.
Yeah,
Amen. All right.
Hey, I was seeing a 50 caliber. How about you, Joel?
I don't
think it
even
looks
know
like
what I
it.
want to think. That's
Right,
priceless.
All righty. Okay, everybody. It's almost 10 o'clock. It's 10 o'clock on the East Coast. So you guys have a good night. And again, next week, same time, same station. We will see you. Dr. Neustadt, again, thank you so much.
Thank you for the opportunity to share. Thank you.
Okay, good night, everybody.
Good night.